learn how to use microphones because you never had to. Generally, when I lectured, people just listened or fell asleep. It was a normal thing for a student in a university. I was an academic in Oxford for the best part of 10, 15 years, doing a whole load of population health and public health epidemiology. I've worked in industry for both Amgen and GSK and ran their epi real world, both for Amgen in Europe, GSK globally. So I've had teams spanning kind of San Francisco all the way through to Tokyo as we kind of brought together things for regulators, so anything was post-approval. I've had some of the weirdest questions you will ever get asked by a regulator, including on, which is pertinent as of what was happening in the US yesterday, on the safety of paracetamol and paracetamol dosing, because GSK, much beknownst to me when I first joined, is the world's largest manufacturer of branded paracetamol. In Panadol. It's now diversified into Halcyon, so we didn't actually have that piece any longer. Ran Our Future Health, so set up an infrastructure where we built out during COVID the ability to take blood samples from between 1,500 to 2,000 people per day at remote clinic sites around the country through a partnership with Boots, through trucks in car parks, through the blood transfusion service in England, Wales and Scotland, and also put in the whole infrastructure. And I now sit on the board of the sample repository for that, where we have the capacity to store 55 million tubes of bloods in fully robotic freezers and do robotic picking and sample storage. I also chair SNOMED, and in my day job, I actually am the partnership business development officer for a tiny biotech, which is trying to develop therapies for an individual person. So how do you take someone's genetic code, work out what the functional defect is which is causing the symptoms, and then develop an RNA-based therapy which will actually treat that child? And these are all pediatrics. They've got otherwise fatal conditions. Half of them probably won't get past age 5 to 10. The majority won't get into adulthood. And none of them have got an actual treatment that's available to them. So we have a partnership, and hopefully before Christmas, we'll start our first trial in Great Ormond Street and work from there. But working through what's the drug will always work. The challenge we have is the regulatory, the system, the reimbursement, the payment, the whole, everything else is a real challenge. Actually making the science is the easy bit for the first time ever in a sort of pharma project. It's normally always you have a molecule and you've no idea what it's going to do, even when you get out of the test tube. So that's what I do for a living. But as I said earlier, the passion that I have is about how we use data to the best possible way. And that's not just, the health care data that we get at the end of it. And I think Lisa and I chatted briefly end of last week as the prep for this session. And, what I'm really passionate about is very much what Lisa is. And, we can kind of talk a little bit about that. But, I've always characterized and, campaigned from a policy perspective to the government is you should be able to access people's healthcare data. It informs a lot about drugs and vaccines and use and public and all those other good things. The reality, though, is that's the worst possible scenario anybody in their health is ever going to get to. If you've actually made it through the door and in front of a doctor, something serious has gone wrong with your health. It is not most of your health. So the fact that you've been hypertensive for 20 years and overweight and have high blood sugars and have all these other things going on, and you're not sleeping very well, and you're struggling with a whole bunch of mental health issues, all of those things don't end up in those clinical notes that I get from the NHS. They only end up there when you've had a heart attack and you've been brought in A&E as a resus patient. They happen when I've dropped things on my hand and crushed bones or things that drop me into there. But also, they also only catch a very small episode of care. So for the work that we're doing on a daily basis, we want to know what happens if you treat a child who functionally can't really move very far, who can't feed themselves, who has 24 hours of care, who, for some of the children we treat, and I saw a referral last week for a potential patient that we're looking at, has between 30 to 100 seizures per day. That is not something you capture by looking in healthcare records. It's all of the other data that sits around that. And particularly the data sit around the parents, the carers, the other parts of the family that become an important part of what it is that you try to do. And that, I think, is really key to breaking down some of the silos that we have, the thinking about where standards play a role and how standards can bridge between health and social care and nursing care and other parts of those areas. Because only by understanding that true piece of the puzzle, which is what actually happens to you as an individual, will we actually make a whole lot more progress about understanding how interventions that work, and how do those supportive interventions wrap around the absolutely essential part of giving clinical healthcare. But clinical healthcare is one small part of it. There's a whole bunch of everything else that goes around the edges, and we're not very good at doing a joined-up picture of those things.
Crikey, follow that. Andrew and I met last week and we had a very structured session, but I've sat here this afternoon and I just said to him, I'm going to go a bit rogue, so sorry about this. Can I ask just how many of you have worked in social care or with social care data? A little bit, some, kind of. Okay, and how many of you from the UK, or work in the UK rather, not from the UK? How many are from other countries? Okay, a few. Okay, so social care in other countries tends to be called long-term care. So just to get that one out of the way, tends to be. So one of the things that I thought is that given it's a very health data focused session, I might bring some social care. So we talking about the social determinants of health and some broader issues around equity and governance, but I'm going to do a crash course if that's all right, Andrew. So as Paul said, I'm from Social Care Wales. We do three things in Wales. We register social workers and social care workers, we develop the workforce, but we also support improvement across social care. And one of the reasons why I'm involved with Becca and Digital Health and Care Wales and the National Data Resource Programme is that part of our mission is to support the improvement of social care, and data is such a massive part of bringing evidence to the system and helping create more seamless care across the system. So I'm going to really abuse my 10-minute slot here, and I'm actually going to show you a video of what is social care, because I will never ever miss the opportunity when I've got health people in the room to do a bit of a thing on social care, but also because often we are fighting against, that's a little bit strong, we are trying to challenge the idea that social care is just a way of keeping people out of hospital. It can be it can be construed as, particularly for those of you in the UK will have heard the expression delayed discharges, delayed transfers of care, and horribly bed blocking. And the reason for that happening is always given as social care, which is simply not true. So I'm going to show you a very short 2-minute video on social care. I think it builds a nice picture, and then talk a little bit about what that means for data. So can I roll? Is that what they say?
Access care and support for various reasons. It could be to get support to establish safe and stable environments, to manage their physical and mental health, or to live independently. Unpaid carers who provide care and support to family members or friends can also access social care. The term social care covers a range of activities such as practical and emotional support, providing information, advice and equipment, safeguarding, and personal care. Social care can take place in a range of settings, including people's homes, care homes, day centres, hospitals, or in other community locations. It's provided by organisations including local authorities, private companies, charities, and not-for-profit organisations. A significant amount of care is also provided by unpaid carers. Tens of thousands of highly skilled, well-qualified professionals work in social care in more than 75 roles. Most social care workers in Wales must register with Social Care Wales and follow codes of professional practice. The codes set standards of behaviour to support people's safety and well-being. Social care workers support people to express what's important to them and set goals by building meaningful relationships that value people's experiences, language, and culture. They support people to identify and make the most of their personal strengths, skills, and support networks, including family, friends, and resources in their local community. They work with people in crisis situations and over the longer term. Social care organisations work with other professions such as health, education and the police to provide services with integrity, empathy and expertise.
A social care worker to me would be amazing, fantastic and caring and help me live a normal life.
To find out more about social care, visit socialcare.wales. Want a career in care? Visit wecare.wales.
I'll let Alison know that she got a round of applause. She'd be very proud. So the reason I showed that is because, we get involved with data projects, particularly in Wales, a project called the National Data Resource, which is about pooling health and social care data, and some other data projects. But I think sometimes it's easy to overlook some of the particular challenges around using data in social care when you're looking at it from a health perspective. So I thought I'd just do 2 or 3 things that are a little bit different, just while I'm here. So first thing is that in every country, the social care or long-term care system is propped up by millions of unpaid carers. And what that means for the care system from a data perspective is that we don't know how much need there is anywhere, because family carers will always step in. So we have an immediate issue, which is you can't measure demand. It's almost impossible. So that's quite different from the healthcare system, where you get some measure of waiting lists or waiting times. So that's one important thing. The other thing is that the type of funding that the system has a massive impact on how you collect data. So you'll find in the US, for example, where Medicare and Medicaid fund a lot of long-term residential care, that because of the insurance systems, they collect a whole range of routine data around conditions and around what providers are actually doing in practice. So you have a huge, probably the US is the only country in the world that has the level of data it has about nursing homes, but even there struggles with things like home care because it's so fragmented. But in every country, whether it's funded by the state or by individuals, you'll find a massively fragmented provision, and often, almost always, a huge amount of private sector provision. So how do you collect that data when essentially people are in a competitive market environment? That was another one. And finally, because I have gone completely rogue, Andrew, is outcomes. So you're seeing from that video, one of the reasons I love that video and why we developed it is that something that is very important to remember about social care is the range of outcomes. It's about autonomy, about having a meaningful life, about being safe. So it's very, you'll have, those of you who've thought about value-based healthcare and patient-related outcomes measures and experience measures, you'll have had a bit of an insight into what it's like to collect data in social care. So, there have been some incredibly good efforts like the Adult Social Care Outcomes Toolkit in England, which is used by the Department of Health and Social Care to measure outcomes across the system. There have been some really good attempts to develop psychometric tools to measure outcomes in social care, but gathering that data is still incredibly expensive and difficult. So I couldn't resist, having sat here this afternoon, to say some stuff about social care, just to get that conversation going. And I suppose even though we are very keen to stress it's not about keeping people out of hospital, it is upstream, isn't it, Andrew, from what you described? So we talked a lot on the phone about Marmot's social determinants of health and how do you measure things much earlier in the system, and about the importance of education and public health and housing and all those things. Social care is on the spectrum, closer to healthcare than those, but is also an important part of supporting people to live independently. So Andrew, back to you.
No, I think you make
That's not what you expected.
But is that, there's just a continuum, and I think that's the big thing, that you kind of, if you start to think about what the NHS is trying to tackle at the moment, which is ridiculous amounts of waiting lists. Aging population dynamics are kind of creating a sort of slurry of differing problems. There's a bunch of therapeutics which is sort of working reasonably well, which are then creating a whole bunch of different problems because you kind of get people with different diseases turning up at different times. And you can try and fix that by trying to fix the health parts of the system, and you can make hospitals operate 24 hours a day and kind of try and solve it that way. Or you kind of pull backwards a little bit and kind of go, well, actually, if you look across the country, health as a concept is massively disparate between areas of the country. You can go, walk across. I grew up in the northeast of England. I can walk between Sunderland and Newcastle, and I can go from life expectancies of 50 to 60 to 70, all the way through to life expectancies of 80 to 90. Now, that is not because I chose to live in one particular area. It is everything that kind of comes together in there, which is accessibility, inequality, the sort of population dynamic and structure, and sometimes genetic heritage as well, because of pockets of culture which live in certain areas of the country or certain areas of towns. And I think that's the importance. There's so many elements that we just don't collect the data on, and we can't plan the services appropriately. And we ridiculously spend all of our time thinking about how do we make the hospitals more efficient, or how do we drive efficiency. And don't get me wrong, I do not believe the NHS is yet in a massively efficient state, but I'm not sure we're going to get a big sort of return on our investment by putting all of our focus there without actually trying to tackle some of these upstream challenges about how you manage inequity, access to care, access to service, access to the educational things that they need. And we know there are so many barriers, and I always use the classic example of people who smoke. Not many people who smoke will actually argue with you that smoking is a good and healthy thing to do, and it has no health effects whatsoever, and it's perfect. People find it incredibly difficult to give up, no matter whatever intervention that you place on them. Behavioural change is one of the hardest things you ever try to do. And it's driven by population characteristics and the societal impact around the individual as to whether you're willing to do that. Everything upstream of getting ill is all about behaviour change just to kind of get you there. And that can be getting you out of poverty, it can be bringing you access to education at the right time and in a way that is accessible to you. It's about providing the right mental health support in the community to address the challenges that you are facing. And it's about understanding and recognising all of those. And that's the system upstream of everything that we do. And, as I said, we're spending a lot of time at the last point of care. We're not really putting the effort into sort of thinking about how do we measure some of that stuff? How do we bring it together? And how do we actually ultimately inform policy decisions at the end of it and long-term policy decisions, because these governments hate it because they're not going to see an impact of changing obesity in a 5-year window. That's not going to change the number of heart attacks coming through the door. It's not going to change the number of strokes. You're going to see the same numbers coming through. In 10 years, you might start to see a bit of an impact. But governments only have a 5-year window at best. Most of them only have about 2 years by the time they've twiddled around for a little bit, done something, measured something, and then they're campaigning for the next election. So the cycle doesn't play itself to long-term policy structure. And everybody has their own view of healthcare and social care, and whether you're conservative, liberal, whatever, they all will do something slightly different. So it's really hard to get policy consistency as well.
Well, one of the things that Andrew and I talked about as well last week is once you're in the health system and once you're experiencing clinical interventions, is the lack of focus by researchers into broader outcomes. So we both shared some examples. I sit on the appraisal panel for our local health technology assessment body, Health Technology Wales. And I remember some time ago we had a intervention which was to test pregnant women to give them continuous blood glucose monitoring if they were likely to develop gestational diabetes. And all of the research was around how long premature babies would be in hospital if their mothers developed diabetes. And so there were two outcome measures. There's one outcome measure is the length of time in neonatal intensive care. And as Andrew and I were talking, and one of the really difficult conversations and frustrating conversations that we had as part of that discussion is the lack of information on the societal cost of having a baby in neonatal intensive care. So, it's the cost to the NHS. But actually, if any of you have had own children in neonatal intensive care, NICU, or if you've known people who do, you'll know that it comes with a tremendous cost to families, whether it be just parents having to travel to the hospital every day, the emotional cost of being without their child, the mental health cost, the cost of giving up work if it's a prolonged stay. And so a lot of the research that we fund and deliver doesn't actually think about these, even with the sort of the ecosystem of health, they don't think about anything other than the impact on the health system. So we had quite an interesting, and you had your own personal experience of this.
Yeah, because earlier this year I became quite unique. I had multiple tears in my retina, which were all laserplexed 1 week. Went back for a checkup, and the consultant was like, "Oh, there's a little one just there. We'll just laser it again." Turned out lasering it again meant that it was a full-on detachment, and I was put on the clinical emergency list for that afternoon to have the middle of my eyeball sucked out, the cryoplexy put it into the back of the retina to stick the retina back together, refilling it all up, and then having the gas bubble that gets inserted into your eye to act essentially as a plaster to stick the retina back to the surface to help it happen. Now, if you read my clinical notes in the NHS, it says patient had a MAC-on retinal detachment, which was replaced by cryoplexy, discharged to home to care, normal recovery. What it fails to capture is that for 5 days, I was as miserable as sin at home and probably annoyed the hell out of my kids and my wife because I had to lie still on one side of my body and could only move for 5 minutes in every 30 because the bubble has to press against the bit of the eye that is detached, which for me was the upper left corner. So I was just laid like that, getting bored. Language subtitle movies, which were not so good if one of your eyes isn't working and you've got a big black thing sitting in front of it. Then the 2 weeks while you still have a bubble and you have no depth perception while you're walking. So at lunchtime, as I went for a walk around the village because I could move, I looked like some drunken person who'd been out drinking at 10 in the morning because I was stumbling off the edge of the curb because I couldn't quite work out where it was relative to my feet. And all of that is sort of trivial, but it's not captured when you actually work out the sort of total cost of care or the total impact of an injury. And even today, I actually don't have perfect vision. I've got to go back because I rapidly developed a cataract almost immediately after the gas bubble injection. It stimulates cataract production relatively quickly. I've got to go back and have that taken out next. And like night times, any bright light, I get shining halos around one eye. Only one of them really works. And all of those things, irritating and annoying, but they're just not captured in the sort of system of when we say somebody had this one procedure, it took 3 hours in the afternoon, they're all done and gone, and they're out of the hospital and they've had their one checkup, and that's all they actually need. When everything else of the impact on you as an individual, and that's true for pretty much everything that you think about in healthcare.
And, I was really struck as well, Kerry, when you were talking. Kerry just shuddered. Sorry, I hadn't never seen anyone do that before, Kerry. One of the things that is also a consistent theme with some of these questions around, if we just go back to social care and health care, is we have very big conversations about data promises and about transparency in patient data and public data. One thing that is very difficult to think through, and I think an organisation, One London in London, has done some of this work really well, is to really think about what we mean by having data sharing between systems. What do we really mean? I may be very happy for people to know, for my housing associations to know that I've had home care support and that I'm under a consultant for orthopaedic care. But I may be absolutely horrified to find out that, say, my mental health records were shared, or my gynecology records, or having been in an abusive relationship, or having a criminal record. So, I think can have some of these very big, important conversations. But I think one of the challenges for us as people interested in evidence and data is about actually doing the hard yards of asking, what are your red lines? I don't want you to share my mental data. What if that could mean that we could do really good research into your condition, and we might be able to give you some support? Oh, okay, well, if I don't know who I am, that could be really, so it's these red lines and important decisions and bringing those questions, I think, to some of this discussion, rather than, it's the governance structures are absolutely vital. The structure of how we support transparency and governance is clearly essential, but it's the devil in the detail that I think we all need to really kind of think through.
And I think if you go historically, we've worked in a world where aggregate, pseudo, and whatever you want to call it in legal terms, but de-identified data became the norm for sort of research. And there's a lot of thinking. I support and advise about 2 or 3 different startups have been trying to think about this, the sort of concept of putting the patient, which is not really the patient, but the person or the human being at the center of owning/controlling, so it's not clear whether it's ownership or control or management or permissioning their data about themselves and how they want that data to be used. And it's one of those horrible things that's really, really simple for me just to say that, the actual practicality of making that a reality. So that how many times do you want to be contacted? What if your data is used 1,000 times a day? Do you really want to be asked 1,000 times a day? What if you give too much consent and blankets, and how would you bring it backwards? And, I do think the world is going to a place where we think a lot more about, I think in the world of ethics, it's the sort of dynamic consenting models that exist. Because we've got to be able to allow the sort of sharing happening, but to allow it to be used in a way that we can each control how we want that data to be shared and for what purposes. Because when you understand that, you become much more comfortable with how it's actually going out there. Whereas, whilst we are all happy to give Tesco, Asda, Sainsbury's, whoever, all of your shopping information, and most of you don't know how informative that is about you as an individual, given how much Tesco's actually make every year from selling that data on sort of shopping trends and patterns and habits. We're not willing to share health data in that way, and equally our criminal records or our tax records or our employment history or our social benefit claims, all of which are incredibly powerful in understanding about you as an individual. But putting much more control onto that is going to be a feature, I think, as we move forward, to not just massively create mass data sets where everything's in one place, but that we've all got levels of control that we're comfortable with about how that sharing actually can happen.
One of my great pleasures in life is being asked to use my club card. I don't know if any of you, I'm sure most of you have Tesco club cards, and you will have been in the situation where someone says, I haven't got my club card with me, has someone got one so I can get the discount? I love that, because suddenly they think I've got a dog, which I don't, or I drink really cheap lager, which I don't. So I love messing with Tesco data, so I'm usually there putting my hand up. If you don't live in the UK, you'll have no idea what I just said.
Well, the Amazon parallel is my wife's manages a publishing list for one of the big publishing houses, and she used to manage the series of books called Teach Yourself, which largely have a language section, but they also have a non-language sort of section. She managed the non-one. The messing up that she can do of an Amazon algorithm over what book you should read next, when I think there was one year she was doing Teach Yourself wine tasting, Teach Yourself how to play golf, Teach Yourself relaxation, Teach Yourself great sex, and Teach Yourself basketball. The algorithm that Amazon then suggests to you that the next book that you should read of all of those combined together becomes a really interesting sort of proposition, which my kids ask many, many questions of whenever they look at her sort of, I think you should be reading, Mum, what have you been reading?
So I think we did the rambling conversation we planned, didn't we? I think, we did say we'll just freestyle it, and we had a list of bullet points. I think we covered 1 or 2 of them. I think that's victory.
I think that was about right.
Yeah. So I think, Paul, these people have had a long day.
Everybody is looking for better healthcare solutions. What if AI could be the answer? AI in healthcare isn't just a buzzword, it's revolutionizing patient care. With AI, we can achieve more accurate diagnoses and personalized treatments tailored specifically to each patient. AI systems analyze vast amounts of medical data at lightning speed, identifying patterns that might be missed by human eyes. This means early detection of diseases, fewer errors, and more effective treatments. But the magic doesn't stop there. AI helps streamline administrative tasks, giving healthcare professionals more time to focus on what they do best, caring for patients. The result? Enhanced patient outcomes and improved quality of life. So whether it's predicting patient needs or making real-time decisions, AI is transforming healthcare, one patient at a time. Embrace the future with AI-driven healthcare solutions. Because better health outcomes start with better technology. Ready to take the leap? AI in healthcare, better diagnoses and treatments, making healthcare smarter, one innovation at a time.